voxel of contrast, or passes through single voxel, while the other one is actually accumulated. Again, we have what we call percentage baseline at peak, or percentage signal recovery. Those are other, again, parameters are important because, so that is the, show you that. So that's the percentage of recovery. I have another slide, maybe I can show you. As you can see, different type of mass or different type tumors, they show different recovery of that. So after it passes the mass, so it sometimes doesn't go back to the baseline level. This is an example. For example, this is, it goes below and even goes up, or sometimes goes to the same level as before the contrast. And mean transit time is the average time required for any given particle to flow through a capillary artery to vein in the unit of seconds. Cerebral blood volume, which is a very important parameter to quantify tumors. It is the amount of blood in a given region of the brain tissue at any given time, and the unit of milliliter per 100 gram of brain tissue. Again, cerebral blood flow is very important, especially in case of infarction, and we need to see how much brain is affected. So it is represent the delivery of blood to tissue per unit time in a unit of a milliliter per 100 gram of tissue per minute. Normal values are 50 to 60 milliliter per 100 gram of tissue per minute. Gray matter is like 50 plus minus 15. White matter is represented 22, again plus and minus 5. So from these two parameters, we can measure mean transit time, and we can actually calculate from cerebral blood volume and blood flow, we can calculate mean transit time. Those three maps are actually very important for us for quantification of perfusion results. So the maps that we acquired is cerebral blood volume, as you can see, and cerebral blood flow, mean transit time. This is in second, this is in milliliter per 100 gram, and this is per milliliter per 100 gram per minute. It's very important to measure at the relative perfusion, because if patient, for example, has infarction, the blood supply will not be the same as normal patient, or for example, an older patient the blood supply to the brain will be different than the young patient. So we have to have at least a reference, or so that reference for the same patient to compare, and that's why we call that is as standardization of perfusion acquisition methods. So it is used to create reference for color maps, and it's used as a kind of normalization. There are two techniques, which the first called global arterial input function, which is based on choosing a reference. This reference will be used for the whole brain. We will show you some example. Or we can just use the local arterial input function, which actually each pixel has its own reference. So both methods are applicable, and most of the machines now, software, they are using both of them. You can select whether to use the first or the second. So this is an example of, in the first one, which you actually locate the arterial input function. You can put it in different locations, and according to the location, you see the curve is varying, and the result will be severe. If you select, if you put it in the wrong place, your result will be mistakenly, evaluated. So this is an example. If we put it in the right place, we will have a good perfusion imaging. If we put it in a wrong place, we will see that it's useless. So parameters extracted from susceptibility, dynamic susceptibility contrast in the intensity curve. Relative cerebral blood volume which is actually based on the IF, we can generate the relative cerebral blood volume, which is more accurate rather than using cerebral blood volume, which is actually the cerebral blood volume in the area of interest relative to the cerebral blood volume in the normal appearing contralateral cerebral white matter. Most tumors have high relative cerebral blood volume than compared to the normal white matter compared to the non-neoplastic lesions. For example, the relative cerebral blood volume of tumors, of high-grade tumors, is 1.8. Because this is a ratio, there is no unit. That's very important because we divide the left to the right, so this is only ratio. So if I show there, that's the tumor and that's the cerebral blood volume maps, and from there we will be able to. And this is, for example, radiation necrosis. The perfusion, the relative cerebral blood volume is low compared to the recurrent GBM. Some tumors commonly have areas of higher and lower grades, so it's heterogeneous, it's not all the same. Radiation necrosis, again, typically demonstrates low relative cerebral volume than white matter. Meningiomas have a very high relative cerebral blood volume. Again, very high means even 7 or 10. Velocystic, again, astrocytoma and schwannoma have a lower cerebral blood, relative cerebral blood volume. The second type is the dynamic contrast enhancement. I'm just now making an introduction. After that, we will come to the technique and just demonstrate how we can acquire both techniques. So dynamic contrast enhancement, which is that other technique based on T1 acquisition, it's employed to characterize the functional integrity of the blood-brain barrier via estimation of microvascular permeability parameters. So this means that it's mainly for tumors, applicable for tumors because the blood-brain barrier is destroyed. So we study the permeability, means the transfer of blood through the blood-brain barrier. During T1-weighted images, dynamic contrast enhanced MRI, the contrast agent accumulation results in a T1 shortening and positive enhancement. So through pharmacokinetic modeling of contrast agent accumulation into the extravascular extracellular space, a number of parameters can be again determined. It is model dependent. Parameters can be again calculated by fitting various mathematical pharmacokinetic models. Common use models of brain tumors including classical Toft model and extended Toft again model, which is the most commonly employed in the clinical application. Dynamic contrast enhancement is used again in prostate in areas different outside the brain. They use it in the prostate. It has an application again recently in the breast and other body parts. But in brain is not as common as susceptibility. Recently, it has really a good number of applications, and it's starting increasing. I mean, using this technique in brain imaging is actually finding its way. The limitation is that the limited software to do the post-processing for the dynamic contrast enhancement. So parameters in dynamic contrast enhanced, which is derived from the curve. We have a parameter called K-trans, which describes the leakage or the leakage rate of gadolinium-based contrast agents from blood plasma towards again, so that the rate of leakage is, so this is frequently called permeability, and is a combination of capillary wall permeability surface area product per unit volume of tissue and capillary blood flow. So it depends, as I said, it's, I think I have some a graph later on, we will see that if the blood-brain barrier is damaged, there will be both ways a movement. And so the K-trans show us the ratio of this type of movement of the blood through the blood-brain barrier. So volume of extracellular, extravascular per volume of tissue is called VE again. It's a quantification of cellularity and necrosis of the tumor again, vessels. Fractional blood plasma volume, it's a quantification of volume of blood plasma. Rate constant between vascular extracellular space and blood plasma called KEB again. It is determined by the equation of ratio of K-trans over VE, and from there we can. So all these parameters are important because they, again, we can identify different type of tumor from these parameters. Again, you can see the shape of the curve is varying according to the type of tumor and type of malignancy. So this example showing the comparison between the two parameters, VB and K-trans, and our susceptibility acquired relative cerebral volume. And we can see for where the area we're having high K-trans. So steps to do, or technically how to do susceptibility, dynamic susceptibility contrast. So patients basically should have an IV line with a needle gauge of 18 or 20 IV. It should be just to be patent and shows no resistance to flow. Again, we should use a power injector, not hand injection, because we need consistency, and then we need high pressure as well. Single shot gradient echo planner, because it's fast to acquire, so cannot be done with spin echo or gradient echo. It has to be done with an echo planner because it's very, very rapid acquisition technique and can acquire images in a very, the whole brain can be acquired with 1 second or so. So if we acquiring, for example, 60 acquisition, we can acquire the whole brain in 1 minute or 1.5 minutes. TE parameters, now there are different setups. We will discuss this in a minute. TE should be from 30 to 60 milliseconds. TR should be 2000 milliseconds. Flip angle from 30 to 45 degree, and number of excitation 1 frame every 2 seconds for 2 minutes, 1.5 seconds or 2 seconds. So the total is 60 frame for the whole brain. Contrast dose should be 0.1 or 2.2 millimole kilogram body weight. Injection rate should be 4 to 5 milliliter per second with a 20 milliliter saline flash. Perfusion technique, again, the gadolinium contrast based contrast agent bolus injection should commence within 15 to 20 seconds after the start of the acquisition. So basically we start scanning and will allow the scanner to be stable. So like we can skip 3 or 4 acquisitions or 5 acquisitions. So basically like 15 to 20 seconds or even a little bit less to allow for the stability, and then to have a baseline on the image. So in case of contrast agent, extravasation is expected. Evaluation of the brain tumors, preload correction approach is recommended. We will discuss again preload and the importance of preload in the. If we combine the two techniques together, which is a trend on some centers, they do both dynamic contrast enhanced and dynamic susceptibility contrast. So they do 2 bolus. So the first bolus, they will do the dynamic contrast enhanced, and after that, they will do another bolus for dynamic susceptibility perfusion. The type of contrast, there is no clear agreement which type of contrast. So most of them, especially if you select those, the least harmful contrast agents will be better. And this is again example of parameters used in dynamic susceptibility contrast. Dynamic contrast enhanced, which is the second type of perfusion, is actually based on spoiled the gradient echo sequence. It's not ABI, it doesn't require to be ABI. We just use the gradient echo sequence with the fast acquisition. TE should be minimum, TR again minimum, flip angle from 25 to 30, measurement like we have 100 measurements. And as you can see, as the time goes, we will see some enhancement from those. We can study the curve by pixel, and from that we can draw the curve. Now, effect of acquisition parameter really is a critical topic, and if that is not really taken seriously, we will have completely wrong results, and we may have underestimation or overestimation of the perfusion. So, as we just mentioned, that blood-brain barrier and leakage effects, dynamic susceptibility perfusion assumes that gadolinium-based contrast agents remains intravascular, thus common disruption in blood-brain barrier in brain tumors can lead to errors in the vascular in the evaluation of the cerebral blood volume. So as you can see, the flow is not as we just expected. It's not the normal shape that we can see the curve. Because of that leakage, some T1 enhancement can occur. So in the contrast medium, that not only it affects transverse relaxation rate, but also it affects T1 relaxation and shortening. So when the blood-brain barrier is damaged, contrast leaks into the extracellular space, which leads to the reduction of the signal through, as we just explained before. And it's also contribute to the shortening of T1 in the extravascular tissue. Now, these two effects can significantly reduce the signal loss caused by susceptibility effect, which we are studying in the susceptibility curve. And this will lead to the quantification error in the cerebral blood flow and volume. So as you can see, it might has overshooting, or it can go, under. This will illustrate the effect of T2 star, and this is the effect of T1 leakage. So that is really an important issue to be addressed. Acquisition strategies, including the choice of flip angle, echo time, repetition time, and preload dose, and incubation time. Incubation time means how much we wait after first injection. So we divide our injection to 2 doses. We do a small amount, a quarter of the amount, for example, and then do, for example, flare, other sequences, and then we will do other bolus with the remaining of contrast. The time between is called incubation time. Again, along with the post-processing leakage correction algorithm, which is available now in most of post-processing software, have been proposed as a means of overcoming these leakage effects. And for example, Lee from University of California in the brain tumor imaging laboratory, they studied like 250 tumors, and they found the following acquisition strategies to optimize protocol, producing high cerebral blood volume fidelity using a flip angle. For example, they found those combination between flip angle, echo time, and repetition time will bring you, and with the preload strategy, will bring you with the best results. So if you are not injecting a preload, you may use those parameters. If you're injecting a quarter of the preload, small amount of contrast, and then you use those equations. And though they studied, they found this is the amount of error. As you go shorter with TE, the amount of error will be less compared with the higher echo time. Again, that is with no preload. And then with higher preload, as you can see, similar again with repetition time. As you go higher with repetition time, the error will be higher. So it's better to have a shorter time, but avoid to have oversaturation. Or again, in this study, they also found that, for example, effect of flip angle, repetition time, and echo time And they, again, after studying a number of cases, they found the best performing preload dosage. For example, if you use flip angle of 35, again, those stars are showing the optimal TR and TEs to be used with each type of preload. Applications of perfusion, we will start with the brain ischemia imaging of acute stroke. The area usually with abnormal perfusion can be dead tissue or tissue at risk. So it is very important to decide whether to have intervention or how much amount of brain is dead or damaged. So combination of diffusion and perfusion imaging will help us to define the tissue at risk. So as we can see, perfusion usually diffusion show higher area, and perfusion show a smaller area, which is shown in this example. This is the diffusion restricted area shown in diffusion weighted images, and that is the perfusion part shows affected by perfusion. So the mismatch area is called the penumbra, which is the area can be saved, or the area can be, if we trying to intervene, it will be, we can help the patient with this part of the thing. The most important role of perfusion actually in the grading brain tumors or defining the type of brain tumors. Again, as we just mentioned, that cerebral blood volume correlates well with the tumors grading. Tumors are frequently heterogeneous when looked at under the microscope. Again, perfusion can help us or guide the neurosurgeons to obtain most accurate biopsy sample of the tumor to optimize therapy after surgery. Perfusion also can help us to distinguish a brain metastasis, primary brain tumor, and an infection process prior to the surgery. So those are all application of perfusion: tumor grading, identifying molecular characteristic, differentiating glioma from other brain tumors, treatment response assessment, again, predicting prognosis. So most tumors have higher relative cerebral blood volume than white matter. Again, for example, as I mentioned, it's 1.8 for higher tumors. Some tumors commonly has areas of higher and lower grades. Radiation necrosis typically demonstrate low relative cerebral blood volume compared to the white matter. Meningiomas have a very high rate. So this is an example of 24 years old woman with a previously treated high-grade brain tumor, which is such enhanced lesion, as we can see in the follow-up MRI. Colored map cerebral volume doesn't show much high cerebral volume, which means that's any go inferred to radiation necrosis. Again, as you can see, grading of tumor can be seen from the perfusion weighted images. As we go higher in the grade, we'll see more perfusion. Again, this is another patient previously treated with high grade astrocytoma with an enhancing lesion on the follow-up examination. Color-coded cerebral volume map obtained using dynamic T2 star weighted technique shows areas of moderate to high cerebral blood volume, an area of abnormal contrast enhancement, which means recurrent tumor, as we can see there. Another important application of perfusion is the differentiating GBM from metastasis, actually. And in the GBM, actually, we see high, intermediate, normal. So this is the mass. The surrounding part of the mass will be intermediate signal or cerebral volume, actually, and then normal. While in the metastasis, we will see like high cerebral volume and then low, and then we'll get back to normal. So this is an example of GBM versus metastasis. We will see that those three regions as we just compared. And from there, we will be able to see, so it's higher signal, intermediate, low, and while in the metastasis will be higher, low, and then intermediate. So it's actually higher, intermediate, low, and then normal. Infection, usually, as we just mentioned, it's always low in perfusion. So, so that is, again, I'm just rushing on time. Other applications of perfusion, like traumatic brain injury, schizophrenia, HIV, drug abuse. We will come to the last part of the talk, which is limitation and technical consideration of perfusion. Dynamic susceptibility contrast is a susceptibility-weighted technique. That means it's sensitive to any strong magnetic field inhomogeneity, especially if patient has any metallic objects, surgical clips, which is the things that we face always. Patient comes post-surgery with the surgical clips nearby, and that can cause severe distortion to your reading. So this is one of the actual challenges of the this technique. Macroscopic susceptibility may also be reduced by increasing the spatial resolution, but that will increase the scanning time, or you have to reduce the number of locations or volume that you need to cover, and also signal to noise ratio. Another disadvantage of susceptibility technique or this dynamic susceptibility is the requirement for injection of gadolinium, which we know the maybe the next speaker can talk to us about this topic. A major limitation of dynamic susceptibility contrast MRI is, again, lack of technical standardization. As we just went through the techniques, the flip angle can be varied, echo time, repetition time, type of preload, how much to put to preload. All these are not standardized. So this can lead to, again, not accurate readings. Perfusion measurements tend to be, again, relative because of their quantification is dependent on the methods, such as placement of arterial input function, the one we shows how that can affect the perfusion. Again, linear relationship between MR signal and gadolinium. All this can, again, delayed of bolus, disruption of the bolus, a partial volume effect, leakage correction, uniform tissue relaxivity, absolute units, imaging. So all these can interfere with your results. Challenging in implementing perfusion. Some people, they find it difficult to apply perfusion in their routine imaging, although it doesn't take much time. But those the challenges, sometimes for example, lack of awareness of perfusion MRI by referring physicians. They are not requesting perfusion, although sometimes can be requested by radiologist himself. Appreciation and experience of perfusion MRI by performing radiologists. Not all radiologists knows how to interpret the perfusion images. Lack of standardization, as we just mentioned, of MRI protocol, lack of simple and standardized perfusion processing software as well, lack of straightforward guidance of how to interpret the results, lack of reimbursement of perfusion. Some, and especially private hospitals, they will not pay for MRI brain, and they will pay for MRI perfusion unless they have special code for that. Again, lack of high quality data showing impact on clinical care. Again, another mistakes or some lack of perfusion. Sometimes we see post-therapeutic some medications which can cause suppression of MR signal in general, and also of the perfusion. So during the treatments, some medications, such as Avastin, for example, which they use in our hospital, it shows a rapid decrease in contrast enhancement, and peritumoral edema is often seen in conventional imaging as a result of significant reduced vascular permeability. So these radiological changes are reported in 25 to 60 of the patients undergoing antiangiogenic treatment, which really mostly this radiological pattern goes together with a temporary improvement in the clinical symptoms. However, it decreased in contrast enhancement and response, and is not associated actually with decrease of tumor survival improvement. Antiangiogenic treatment can potentially focus on any of the prognostic factors involved in GBM. So this is an example of, you can see that pre-contrast, this is like for after treatment. And as you see, the perfusion can, be better than even the contrast because it can see some, but this is not the real case. Actually, if the patient was not on that avastin, for example, will show more exaggerated perfusion. So that's an example of, again, of another type of response to the agents. Thank you so much for your time, and I'm sorry if I exceeded my time, but the topic was really too long. Maybe we can leave the questions to the end, and let me just open the, how to do, just a second. I will stop share my, okay. Now I will leave the floor to our next guest speaker. She's MR, sorry. So Miss Zen Lipa, hopefully I pronounced the name correctly. She's a contrast media application specialist in Europe, GE Healthcare. So please proceed.
Thank you for giving me the floor. Dear professors, radiologists, and technologists, ladies and gentlemen, good afternoon. I am Zana Liepa, contrast media application specialist working for GE Healthcare Eastern Europe. And I will share the screen, just a minute. This is my presentation. So I hope you see it.
Yes, it's clear.
Yeah, okay, thank you. Then I can start. I'm highly honored by this invitation to speak with you about gadolinium-based contrast enhancement MRI imaging. Thank you very much for this invitation. It's really a challenge to speak in completely different region, but I hope that my presentation will make sense for you as well. Dr. Abdullah brilliantly covered MR perfusion method. Therefore, in my lecture, I will take a more general look at other contrast media enhanced MRI examinations, focusing on peculiarities of contrast agent injection protocols and factors that may influence them in some of indications of dynamic contrast enhancement. As this is the first time when I speak with audience outside the Europe, especially with Saudi Arabian Professional Society in Radiology, I would like to say some words about myself. I am a certified radiographer located in Riga, Latvia. That is a part of European Union, if somebody haven't been in this part of the world. And for the last 10 years, after I finished my studies of radiography at Medical Faculty of University of Latvia, I'm completely involved in CT and MRI contrast media application. And for the most part of my work, I help to optimize and adjust contrast media injection protocols, considering more safe and individualized approach. And my clinical and practical knowledge is based on both local and international experience. For example, Vienna University Hospital in Vienna or Sapienza University Hospital in Rome. But let's focus on the presentation. And before I start, I would like to remind you that all materials and examples contained in this document are intended for education purposes only. And if we look to the content, then I've highlighted 2 points. I would like shortly define the static and dynamic contrast imaging, and then continue with examples of contrast agent injection protocols for some specific MRI examinations. Gadolinium-based non-specific extracellular 1 molar or 0.5 molar agents after injection initially distribute into intravascular space, that is meaning in the vessels, before rapidly diffusing across the vascular membranes into the extravascular interstitial space and eventually establishing an equilibrium between both compartments after approximately 10 minutes. And so these agents are cleared yet slowly, exclusively by the kidneys via glomerular filtration. Also, Clariscan 0.5 molar macrocyclic agent belongs to this MRI contrast agent group. And as a macrocyclic agent, Clariscan has an excellent safety profile with the highest thermal and kinetic stability and lowest number of acute reactions in this group, and therefore have a wide range of indications, and some of them we will discuss today. Considering this dual behavior of contrast agent and 2-compartment model in the context of contrast agent application, we may distinguish 2 types of gadolinium enhancement in MRI. This is a static contrast enhanced tissue imaging, and the second one is a first pass dynamic imaging. The static contrast enhanced imaging relies on diffusion of contrast agent into extravascular space and is the most routinely used imaging method, which utilizes 2:1 weighted contrast enhanced MRI sequences and displays contrast enhancement at a single point in time, mostly with morphological information of the tissue. In this case, only manual injection is required, and although injection protocols for static tissue imaging are not complicated and mostly standard dose is used, there are some points where I would like to draw your attention. And regarding the brain MRI, as already the doctor in the previous presentation, it was pointed out that decision should be taken about the perfusion MRI for which patients and indications to use this perfusion weighted imaging or dynamic susceptibility contrast MRI, because it requires a different contrast agent injection technique and protocol and patient preparation. And the second point where I would like to draw your attention is about the decision about the dose of contrast agent, because, for example, Clariscan allows to use as an increased dose for central nervous system pathologies in adults, and several studies have evaluated increased contrast dose to improve lesion detection of the brain, for example, metastasis, while increased contrast dose may reveal additional lesions. The added value of these findings has yet to be established because it also may increase the false positive results. Of course, the static MRI imaging method is indispensable in MRI, but dynamic contrast enhanced MRI offers additional diagnostic value and functional information. Therefore, currently it is widely accepted and used imaging method, especially in oncology. And as previously pointed by Dr. Abdullah, there are 2 types of dynamic imaging in MRI, that is a dynamic susceptibility contrast and dynamic contrast enhancement, which is in a focus of my attention. And it involves the rapid acquisition of T1 weighted imaging and before, during, and after administration of contrast agent, and is used for evaluation of organs in whole body. From contrast agent application point of view, further division is necessary of dynamic contrast enhancement because temporal resolution requirements vary significantly by organ system and type of image analysis to be performed. Consequently, it influences contrast agent injection parameters too. And depending on temporal resolution and analysis method of acquired data, I would like to divide dynamic contrast enhancement in qualitative dynamic contrast enhancement, which involves visual analysis of dynamic imaging and is characterized by the low temporal resolution or imaging at the separate time points, also called multiphasic imaging. And the second type is a quantitative dynamic contrast enhancement, also called the perfusion, and it is characterized by the high temporal resolution in the range of 1 to 30 seconds and quantitative or semi-quantitative image analysis of acquired functional information on tissue vasculature. Why this high temporal resolution is required in this type of imaging? Because better time resolution will improve the characterization of the bolus while passing through the body region of interest, in particular in these, if these images are to be treated by the mathematical techniques to analyze bolus behavior. In this example, you see semi-quantitative analysis, which is simply a version of analysis resulting in a time signal intensity curve. And the second example is a quantitative or pharmacokinetic model-based analysis of dynamic contrast MRI data. The choice of image acquisition technique and contrast agent injection protocol and temporal resolution will entirely depend on the analysis method to be employed. And this in turn will be chosen to optimize the amount of diagnostically relevant information that can be extracted from the data, which will depend on the organ system and the pathology being studied. The diagnostic and clinical relevance and application of acquired data with dynamic contrast enhancement and the methods of analysis undergo continuous research, discussions, and the pursuit of agreement and standardization. For some organs or organ systems, for example, prostate or liver, you may find some general standards, including MRI technique and contrast agent injection parameters, but some of examinations are still dependent from the radiologist's knowledge and preferences. Generally, the dynamic sequences and contrast agent injection protocols can be tailored depending on the planned method of analysis. For example, high spatial resolution with a reasonable temporal resolution imaging is sufficient for the semi-quantitative time intensity curve analysis, but a very high temporal resolution with a reasonable spatial resolution is critical for quantitative kinetic analysis. And these are the general guidelines of contrast agent injection protocol in dynamic contrast enhancement. And as I said before, protocols for contrast administration vary depending on dynamic sequence. Mostly the standard dose or 0.1 millimole per kilogram is used, but as I said, always the product label should be followed, and it requires bolus injection with a variable speed of injection between 2 or 4 milliliters per second, although dynamic susceptibility contrast may require a higher speed of injection, but here I speak mostly about dynamic contrast enhancement. And it is always recommended to have a normal saline chaser injection with the same speed post-bolus injection. And as I said, the indication is a whole body. And let's look at some examples by type of the dynamic contrast enhancement. And we start with the quantitative dynamic contrast enhancement examples. And most widely used, of course, is the prostate. And dynamic contrast enhanced MRI is indispensable part of multiparametric MRI. And according to the PIRATS, that is a prostate imaging reporting and data system designed to promote global standardization of the prostate multiparametric examination, the temporal resolution of the prostate dynamic contrast enhancement should be less than 15 seconds. But mostly in practice, it is shorter. But it depends on MRI system capabilities and spatial resolution requirements and other parameters and preferences, but preferably it should be between 5 and 8 seconds. Why acquisition times greater than 15 seconds are generally not used? Because due to difficulty detecting early enhancement and capillary transit time, that is less than 5 seconds. Although here is a relatively standardization of MR imaging protocols for prostate, there is still no final consensus on the best method of acquiring dynamic contrast enhancement data. But no, ideally, the acquisition should be obtained approximately every 5 seconds to allow the detection of early enhancement. We see that PIRATS and other studies recommend the standard dose of contrast agent, that is 0.1 millimole per kilogram body weight, with some variations of injection speed that could be due to different temporal resolution, concentration, or relaxivity of the agent. But PIRATS does not make any differentiation between injection protocols of 1 molar or 0.5 molar agents. From experience gained at Sapienza University Hospital in Rome, where Clariscan was used for prostate MRI in 3 Tesla system, and temporal resolution was 5 seconds, and Clariscan was injected with a speed between 3 to 4 milliliters per second. Additional tip by the radiographers was given to start MRI scan 2-3 seconds later with a Clariscan as compared with a higher concentration and relaxivity agents. The next is a bladder, and similarly as in case in prostate multiparametric MRI in 2018, as a document called VIRATS, what is a vesical imaging reporting and data system, was published. And this document also recognizes that multiparametric MRI and dynamic contrast enhancement is a useful technique in staging and grading of the bladder tumors. And VIRATS includes also recommendations about gadolinium-based contrast agent injection. And if the standard relaxivity agent like a Clariscan are used, then the standard dose 0.1 millimole per kilogram is recommended with a speed of injection between 1.5 to 2 milliliters per second, taking into account that temporal resolution is not high in this case. Although if semi-quantitative or quantitative measurements are used, they most probably require a higher temporal resolution, and thus, in that case, it may require to change the contrast agent injection protocol as well. Depending on indication and local radiologist preferences, dynamic contrast enhancement can be used for head and neck soft tissue tumors. But in the review by Gadolinium and the colleagues of head and neck cancer, it was recognized that dynamic contrast enhancement imaging is in its early stage for this indication, and substantial variability exists in quantification methods and parameter choice and analysis methods. But the dynamic contrast enhancement of the neck soft tissues is routinely performed using clariscan bolus injection by Professor Marco Franconi in Sapienza University Hospital in Rome with a similar protocol as you see in this example. These were just some of the examples of quantitative dynamic contrast examinations. And before I move to qualitative dynamic contrast enhancement, let's repeat some of the important points. That in case of the quantitative dynamic contrast enhancement, temporal resolution is high due to the analysis methods, quantitative or semi-quantitative. Speed of injection is still can be considered moderate, especially if we compare with computer tomography. But in case of dynamic susceptibility contrast imaging, the contrast speed of injection is higher. Gadolinium-based dose is a standard or according to the manufacturer labeling, and applications is a whole body, including prostate, cervix, bladder, rectum, and other soft tissue. And let's move to the qualitative dynamic contrast enhancement, which is characterized by the low temporal resolution, that is T1 acquisitions at the specific time points and visual image analysis. From application point of view, I would like to look closer at the liver, kidneys, and pituitary gland. And due to the liver dual blood supply, various phases of enhancement of the liver are necessary. Because different hepatic tumors may enhance differently at separate time points of the scan, depending on the tumor vascularity and blood supply. Also according to the LIRADS, what is the liver imaging reporting and the data system. Yeah, that also shows some aims for standardization of the liver imaging and reporting. And usually 3 to 4 phases are necessary. From the technical point of view, the important point to consider is the timing of arterial phase in order to acquire MRI images during the late arterial phase. That is preferable for the further evaluation of arterially enhancing lesion over the early arterial phase. And if fixed scan delay is used, then according to the papers, it achieves a correct arterial enhancement in only 61% of the cases. And therefore, this technique is recommended only if tracking techniques are not available on the particular MRI scanner. For the dose of contrast agents, LIRADS recommend to see the label of manufacturer's recommended dose, and injection rate is low, between 1 to 2 milliliters per second, taking into account this low temporal resolution. But in a practice, mostly contrast is injected with 2 milliliters per second, followed by the saline infusion. And LIRADS does not recommend one type of the agent over another, recognizing that the optimal agent selection depends on the patient, radiologist, institutional practice, and other factors. Another application could be kidneys. Even if computer tomography remains a dominant imaging modality, MRI is increasingly used for assessing the kidneys and urinary system. And there are several methods used by different groups for assessment of renal pathologies by MRI, including also both quantitative and multiphasic dynamic imaging. In case of multiphasic renal MRI, the examination involves scanning at 5 to 6 time points or phases, and also for arterial phase or corticomedullary phase, the bolus tracking is recommended. In 2020, the French Society of Genitourinary Imaging published the document aimed at achieving consensus of patient preparation and imaging protocol for renal multiparametric MRI in adults. And in this document, multi-phase contrast-enhanced imaging was also considered a mandatory part of renal MRI. And they agreed that unless contraindicated, an intravenous injection of contrast medium should be systematically performed, and the contrast medium should be injected at rate between 3 or 4 milliliters per second, although in the studies we may see good results also with a lower speed of injection, like 2 milliliters per second, taking into account again the temporal resolution in this case is not high. And the last indication which I would like to mention is for the pituitary adenomas. Although the most of adenomas are detected even on non-enhanced MRI, microadenomas may become visible only after contrast injection. And differentiation between micro and macro adenomas is based on the size of adenoma, and all lesions smaller than 10 milliliters are considered microadenomas, and in that case, dynamic contrast enhancement can be indicated with half dose of contrast enhancement, contrast agent, including a Clariscan. The temporal resolution is intermediate, and therefore the speed of injection is between 2 or 3 milliliters per second. And the maximum image contrast between the normal pituitary tissue and microadenoma is gained about 30 to 60 seconds after bolus injection. And most of microadenomas appear as a relatively hypointense lesion within an intensively enhancing pituitary gland. And the main points about qualitative dynamic contrast enhancement from temporal resolution point of view, it is low or multiphasic. Analysis is qualitative or visual, and therefore speed of injection is low or moderate. Gadolinium dose again is standard or according to the manufacturer labeling, and application is liver, kidneys, and some of the central nervous system lesions. And this brings me to the end of my presentation with some take-home messages that gadolinium-based contrast agent protocols depends on type of contrast enhanced MRI, and in case of dynamic contrast enhancement injection, the gadolinium-based contrast agent injection protocol should be adjusted according to the acquired data analysis method and temporal resolution. And static and dynamic contrast enhancement can be performed with a wide range of contrast agents, including Clariscan, which is the safest macrocyclic 0.5 molar agent with the highest thermal and kinetic stability among this group of the agent, and it leading to the wide range of indications, starting from the neonates or babies of 0 age for the brain and the whole body for the patients above 6 months of age, and also angiography for adults. And as regards the quality and reliability of Clariscan, then this agent is completely in-house produced by GE Healthcare, and Clariscan has been marketed in Europe since 2017 and received marketing authorization in more than 50 countries worldwide with a great success, leading to more than 4 million patient administrations at the end of 2019. And in the same year, Clariscan received approval from US Food and Drug Administration. And let me express my hope that introduction of Clariscan in your countries will improve the diagnostic services to the patients and continue GE Healthcare and your efforts for more effective and safe medical care. Thank you for your attention, and let me remind you that virtual European Congress of Radiology has started today, and at least the visiting of virtual exhibition is free of charge through this website. And let me wish you a great evening and bring this knowledge what we have acquired today to the life. Thank you very much.
Thank you very much, Miss Lina. دكتور عبد الله شكرا لك، الله يعطيك العافية ما قصرت.
Thank you very much for you.
شكرا لكم والله يعطيكم العافية، ونلتقي إن شاء الله في الدورات القادمة إن شاء الله.
مع السلامة.